next moderator who will be coming up and leading our healthcare leaders in a very, very invigorating talk story that's going to happen momentarily. So I'd like to now recall our Hawai'i son, our entrepreneur, our leader of the community. I'd like now to welcome, let me see, John DeFries. Let's give him a big hand.
So both the mayor and Congresswoman Tokuda spoke about the value of voyaging and the examples and the time spent with Maui Voyager and waterman Archie Kalepa. In May of 2014, when Hokulea was about to embark upon the round-the-world voyage, Navigator Nainoa Thompson asked me if I would host a delegation from Google X, at the time the R&D arm of Google. And what we learned was that in Google X's vocabulary, when they look at pioneering efforts, in their vocabulary they talk about moonshot thinking. That at the time President Kennedy asserted that America would go to the moon in 10 years and back, we didn't know how to do it. The country didn't know how to do it. But by pointing toward that vision and holding fast to that commitment, the nation learned its way to doing that. And so before Google X even knew Hokulea existed, they had determined that in the course of human history, that the Polynesian navigators and the Polynesian voyagers were among the first moonshot thinkers in human history. That they had developed a way of sailing into the wind. And you only make new discoveries if you sail into the wind. My whole point, and so we spent about 4 days with them, and we were in Hilo. The departure was delayed due to bad weather. And after spending the time with them, the head of the delegation was named Richard Duvall, and I had a morning with Richard and the 3 members of his delegation. So I said to him, hey Richard, now that you've been here for 3.5 days, what's the moonshot idea for Hawaii that would help humanity? And he said, we knew you would ask this question, and so we met on it. And what we determined was that the Aloha Spirit was the most important contribution you could make. Our concern is that for many of you, it comes so naturally that we don't want you to take it for granted. You need to teach it, you need to nurture it, you need to protect it, and I hope you determined to share it. We travel the world. Technology is not going to pull this out on its own. It's going to come down to human beings treating one another with civility, with respect, with dignity. And we would encourage you to focus on that. And for me, the idea that this tech giant had somehow distilled that this essence of who we are as a people was the most important element that we could do, was at first disorienting, but also very uplifting. And now, before I call our panelists up, I wanted to acknowledge that you and I are convening in a place that bears a very special name, Hapuna. Ha, the breath of life. Puna, the source. And what I'm going to ask you to do, including the panelists, is to take a few seconds, and I want you to think about the one place on this island that rejuvenates you or inspires you or may even cause your spirit to soar. Rejuvenates, inspires, causes my spirit to soar. Think of the one place on this island that does that for you. What time of day? Is it Mauka? Is it Makai? And hold on to that space. Invite that space into this room because we're going to need it. We're going to need that kind of strength to embark upon the sail plan that is contrary to where we've been over the last 150 years. And so with that, I'd like to ask our panelists to now come forward and take to the stage, and we'll get started with this. Clayton McGann, Dan Brinkman, Richard Taff, Greg Christian, Dr. Linda Dolan, and Dr. Whitney Lim. Please join me in welcoming them to the stage. So when Randy asked me to moderate this, I was like winding down at HDA, thinking more about tea times than work, and then he came. One of you can take the end seat if we, yeah. Thank you. And Randy asked me if I would do this, which meant I wasn't going to say no to Randy, but I also knew I needed to do some homework. And then I, realized I get something called the Becker's Hospital Review, and it's got the top 15 states. They're ranking the states that are best for doctors and worst for doctors. And you're in trouble when they're ranking the states, and Hawaii was number 51. Right? Which then took me to the next report. There's something called Wallet Hub that does a whole bunch of stuff. And so it's really clear that not only are we challenged on the island to deliver to underserved people and communities, but as a state, there are a whole number of factors that put us on the wrong end of these surveys. And so what I'm going to do is open this up by having each of you, number one, I want you to identify the one place on this island that rejuvenates, inspires, and may even cause your spirit to soar. So who has the mic? You can just move it freely up and down the.
Can you hear me?
Sure. Yeah. You go ahead.
One place on this island that inspires me? That's easy. That'd be my front row. I look out, so we're on the east side of the Honolulu coast, and it's not always sunny, but the sun comes up over there, and sometimes it clouds in the sun, and like when day breaks, I thought, I'm fortunate in how I live, and that inspires me.
Great Christian. That's a tough one. I think for me, 2 years ago, my wife and I celebrated our 35th wedding anniversary at the Mauna Lani, and that beach and that view just gave us a chance to really reflect, but also appreciate what God has given us. both in the view as well as in our marriage.
This is on. Given what happened just a little bit ago, Manalani talk story with Danny and Hannah, being there at the full moon when you hear the stories and you hear the history and the music of that place and of the island, that always lifts my spirit. And specifically because Danny is doing it.
You know, I've living here 10 years almost, and 2 weeks ago was the first time I ever went to the top of Mauna Kea and watched the sunrise. And it was so touching, and you could feel the mana, the spirit there, and it was just a beautiful place.
John, for me, I think it's the North Hawaii community, specifically the hospital. It's the place where I've been the most frequently and gotten to know the providers and members of the community.
Liliuokalani Park, early in the morning, by the ocean, so I can see that as well as the mountains.
You know, and I'm going to reaffirm that if Kaniela was in this room, and there's no doubt in my mind that he would have referenced Kalahui Pua'a, right? The fish ponds, and the magic that that place provides, and the foundational feeling and support that he and Anna feel when they are there. Those lands once belonged to the Brown family, Francis Brown, whose nephew Kenneth Brown became the board chairman of Manalani, and at the same time, Kenneth Brown was also the board chair of the Queen's Health Systems. And Kenny became instrumental in recruiting Dr. Earl Bakken, who resided at Kiholo, and got Earl excited about the possibility that Northwest Hawaii Hospital could present. So in the calling forth of, in that opening of Homai, that there is no doubt in my mind that for Kaniala, the memory of Dr. Bakken and Kenneth Brown is very much a part of that. But what I'd like to do, and Dr. Dolan, maybe you can start with this, is what are the opportunities for organizations such as yours to help with addressing these barriers that are creating more access, barriers and creating more access points to provide health care?
So I wanted to thank Randy for coming up with a hard question. But I just want to give a little bit of background. The Big Island Docs is an independent physician organization, which used to be called East Hawaii IPA. And what it is actually a organization that brings together private physicians who have private practices, mostly in East Hawaii, somewhat in West Hawaii and the North. And we have about 63 members. The members are physicians, nurse practitioners, physician assistants. And it was created in 1994 by 4 physicians who are actually still practicing in our community in East Hawaii. And it was formed initially to work with the payers in regards to making contractual agreements to be able to provide services for our patients in our community and get paid for those services. It's grown a little bit since then in terms of, we actually, historically, you asked about what programs we've done and stuff. Patient education, we had one of the first asthma education years ago when the VOG was always around and stuff. That was many, many years ago. And since then, we've grown in terms of creating opportunities for our physicians to have similar electronic health records. We've negotiated some contractual stuff, as well as being able to pivot. The most recent thing, of course, and be nimble is with COVID, and working with some of our partners who are sitting right here on the couch in terms of getting our patients vaccinated and all of that. We have an aging population of physicians, which everyone knows. In our organization, we have hundreds of years of medical people. And what I mean by that is our physicians are aging. If you add up all the years, it's like, wow, that's a lot of years of practice. That's a good thing, and it's a bad thing. Mostly, we're solo practices, and we're finding that it's really hard in terms of economy of scale, being able to continue to practice in a solo situation. So we've tried to work on creating group practices, because no one wants to do call by themselves, to be honest with you, as well as you want to have that community and what we call team-based care. So a few years ago, we organized and started on our own a private clinic called Big Island Healthcare with the support of the physicians who are in our organization to create a place, a landing spot for new physicians, and matching that up with some more senior physicians and mid-levels in the organization to start to provide access, better access, more access in that. So those are just a few things that we've sort of started on and continue to do. The struggles with that is financing, funding. We won't even get into the payment structure, which will be, I think, a bigger topic, but I'll stop there.
Dr. Lim, I'm going to ask you to address the same question.
And then I just want to say partnership-wise, we've created some partnership with organizations here at the Couch.
Thank you. So I'm a surgeon, so I'm going to be a lot shorter in my response.
Whitney, that's why we need more primary care.
I'm going to speak in bullet points. No, I'm kidding. So, Queens is having North Hawai'i Hospital. That's an access point, and we try to fit in as part of the healthcare ecosystem on the Big Island. Additionally, we have DLS. It's a laboratory, and what I'm trying to do is use those laboratory sites as access points beyond just blood draws and urine sampling. The next one, it's telehealth. With policymakers helping us with funding, we're trying to push telehealth into the rural communities, areas currently without broadband. And then the last comment I'll make is Queens is a strong supporter of the medical school and the residency program. So we spend about $20-some million a year teaching the doctors of the future. And I think moving forward, we need to make sure that we have people from the Big Island coming, getting their degrees, getting their residency training, and coming back here to train. People want to be treated by providers who talk like them and look like them. And that is something that I think is a priority for the health system.
I think you have a little bit of primary care in you. From the West Hawaii side, when we talk about barriers, I believe in healthcare, each electronic medical record system speaks its own language. And from our standpoint, we just integrated with our partner here, Queens, with their electronic medical record, Epic. Not the same one as the county. I don't know if anyone from the county's here, but what that has done, it has opened up these access points on the west side. Essentially, all of the west side now has the same electronic medical record, which improves the communication, which makes it easier for referrals, which makes it a lot, it opens these access points. So now we can better communicate with the physicians, with the patients, and the employees that serve. So.
Richard Taff, Hawaii Island Community Health Center. I think one of our strengths is certainly that we're serving 80% of the county. We have 15 locations. We're moving into school-based clinics. So we're in all aspects of the community, the most rural areas of our community. And as a federally qualified health center, our focus is about working with those who are disadvantaged, those who are low income, those who come from different populations, who have language barriers, who have financial barriers, who have transportation barriers. Our outreach to the community is huge, and I think that's one of our greatest strengths. The other one of the other ones is, as you just mentioned, Clayton, is around data and the sharing of data. We've implemented Epic now, and so we can communicate with Kona Community Hospital, Ali'i Health, Ambulatory Surgery Center, Queens, and HPH. All of those hospitals, by a click of a button, we can do that. And I'll just give you one brief story about that. We implemented Epic about a year ago. Within a week, one of our dentists came and said, you know, this is awesome. We provide medical, dental, and behavioral health. This is awesome. I just saw a patient who had been at Queens, couldn't remember what medications they're on, what the issues were. It was an older person. And he said, I could click on the button, saw what happened, was the issue, saw that that patient was on Coumadin. Those of you who are familiar with that's a blood thinner. They were going to do a root canal and an extraction, and he said, we can't do that. That sharing of data like that makes a huge difference. And I would just say having a common data system is huge.
There are a lot of barriers. I think, John, I think one of the things that's wonderful is today is an opportunity to talk about those barriers and build some new relationships. And I think all of our organizations do community health assessments to understand what the needs are. And I know for many of us coming out of COVID, all the other things that are surrounding us, unexpected, certainly Lahaina and other things, we have our head down. It's an opportunity to kind of just step back and say, as we all, I would imagine if we all compare our community health assessments, I bet 90% of it's the same. And so how do we then have open, trusting conversations to really assess where we can really connect with one another? I think that's really important. Kaiser Permanente has been here in Kona and on the island for about 37 years or so. We only have, as everyone knows, we're an integrated delivery system, very unique in that we have our own hospitals, our own clinics and doctors, and our own health plan. So it's a closed system. Yet we have a pretty robust community benefit program where last year, for example, over $52 million invested back in our communities. So one of the things I love most about my job is 3 to 5% of our revenues, not our margins, but our revenues go right back into the community. And I think where we do our best work, and I've been with the organization since 1996, most of my career in Southern California, is where we can rally together like this and really be open and honest about what our resources are. Yeah, we compete with one another. There's always going to be that element. But we also have something very much in common as not-for-profits, and that is how do we strengthen the safety nets of our communities and how do we help each other? And that starts like with today, with really good open dialogue and start to build relationships of trust.
Well, hello, I'm Dan Brinkman. So I represent the East Side, which I think you have some there, and all of us here have some impact in that area. So I'm at Hilo Medical Center, and we also have hospitals in Ka'u and in Honokaa. And you know, the questions we ask about what are the barriers to health and access, a lot of them are resources. If I just kind of distilled it down to what we could do, what would benefit the healthcare on the east side or on the island, I would just say more. Because I think the Congresswoman mentioned that, in rural remote areas, the life expectancy is lower, mortality is higher. And in our experience, especially recently, is because if it's not there and it's not local, people don't access it. They're not treated. And they go, well, that's life. And that's just not acceptable, right? So I think that in East Hawaii, a lot of what we've worked to do is to leverage some of the programs that were available for us and grow services. Our board basically took a pretty straightforward approach. Is if you're a remote town of 60, 70,000 people in your surrounding area, maybe a little more, maybe up to 100, what services, if you're an American, should you expect? And let's get them. We were very blessed, and the congressman was talking about rural health programs, the critical access hospital programs, a federal program that some of you may know nothing about, but Ka'u Hospital and Honoka'a Hospital are part of that. And it's designed for rural health communities where it basically allows you to cover your costs for Medicare and Medicaid patients to get those services in place. And we've been able to kind of stitch together between Hilo Medical Center and those in Ka'u Hospital, basically a network of clinics and specialty services in a really rapid fashion and make that sustainable. And I know that program has great red and blue state support because it's really, I didn't realize the percentage was so high, but to have 97% of the landmass and only 15% of the population, that kind of describes us, right? So we're trying to address that and take advantage of what is there. But I don't think we'll ever get to where we need to be unless we can all work together, because we all each have very important missions and we only can do part of the work. And together, maybe could do all the work.
You know, I'm going to jump right into some of the questions we're getting from the audience. And Dr. Lim, what can we do to open licensing reciprocity? And I've heard of a licensure compact or talk about that, but what we'll do is just jump to each of you on these questions. If you have something on this topic, please jump in.
I'll start. I think it's a very practical concept, and I would imagine the next speaker, the guy coming in on at lunch, that'd be the person to ask. I think there's great value in that, allowing practitioners, nurses, physicians to come in. I'll leave it at that.
Anybody, anything else to add? Richard, is healthcare literacy an issue? Literacy, healthcare?
Absolutely. There's no question. Story. We've had people who are of Marshallese. They speak Marshallese. And this isn't a criticism of anybody, but I know they've gone to the hospital. There's nobody who speaks Marshallese there, and they're treated, they're sent home, and they don't know about the medication, and consequently, they don't take the medication, and then they're back and readmitted to the hospital. But again, it's just a revolving door, and that's just one example, but literacy across the board in terms of language, but it's also health literacy and understanding the health. How many of us understand the medications? How many of us even, we can look in the back and, oh, okay, this is what I'm taking. I know I go to the doctor and I say, what was that I was taking? Oh, I don't remember. And fortunately, having a medical record, they can pick it up and see. So yes, health literacy is huge.
So, Clayton, I'm sorry, Dr. Lin.
Yeah, I just want to jump in on this. A patient mentioned to me, I need a healthcare BFF. And I said, what does that mean? There's someone that I know and trust and help me translate and help me navigate. And I think in rural communities and other communities, there are community health workers or navigators that are given that responsibility.
After I got off the stage in our prayer for Kaneala, Clayton came up to me and thanked me in Tongan. And this question has to do with your thoughts on culturally based healthcare.
Yeah, it's very meaningful to me because I, lived in a third world for some time. And I remember going to the hospital there, and they just give everyone a little red pill, and it just seemed like everyone got it for whatever it was. And I just didn't understand that, but I think it was acetaminophen, and that seemed to solve everything. This is an important question because we are in an incredibly diverse area in the world. So kind of going off of what Richard said, that language barrier is extremely tough to navigate. And Dr. Lim talked about healthcare workers outside of the system, right? Outside of the hospital, outside of the clinics that can help people navigate. I think that that's an opportunity when we look at that. It is extremely hard to find social workers and those that fill that critical need. I know we have positions still open at the hospital that we can't find caseworkers. So this is an opportunity I see because we have to start thinking ahead. The younger generation, what's going to inspire them to want to be a caseworker or a social worker? So I think that that's where we want to focus, is inspiring the youth to want to come in to these roles that maybe they don't want to be a doctor, maybe they don't want to do these things, but there's a place for them in healthcare. I'm a great example of that. I started my career as a volunteer in the hospital, handing out blankets. No matter what, there's an opportunity in healthcare, I can assure you that.
Early on after North Hawaii Community Hospital opened, I happened to be with Earl Bakken on a day that the pharmacy there was authorized to issue, I think it was 3 Hawaiian herbal plants. And I don't recall what the plants were, but I remember how much joy it brought to him to know that that was possible. Now, is that sustainable? How do you go about getting that into the system? Remains to be seen. It reminds me of when I was 16, body surfing just north of Huggles in that bay, right? And I'm with my 10-year-old cousin, I'm 16, and I surfed a wave too close to shore. It's all rocky there, and my right knee runs into a rock, and there's an inch gash, but it's deep enough that there's blood flowing, right? And I'm kind of an urban guy, and my cousin lives in Kona. So I'm signaling to him that I'm bleeding, and I got to get out of the water. And he stops me and asks me to sit on the pahoehoe, the rock. And about 15 feet in front of me, he's diving and comes back up, goes back down. Third time he goes down, he's got a certain kind of limu, seaweed. And as he's approaching me, he starts chewing it. And then he slaps it on my knee. Right? And then 30 seconds, the bleeding stopped, right? I'm thinking to myself, here's a 10-year-old, right, that kind of has this knowledge of what it is. So I think this point about rural communities, Native Hawaiian, Pacific Islander communities, there is this orientation toward culturally based, right? I can recall my grandmother's kitchen outside the door were all the plants, right, that you needed for an earache, bad digestion, skin rashes, everything else. So there's a lot to be said about that. Here's another one. Many families in rural areas seem to consider their lack of access to care is just how do we shift that dialogue so that they do not feel disconnected or disenfranchised? Any of you?
I'll just jump in and then pass this on real quick. I think it's one of our goals, and certainly as community health centers across this country, one of our goals is 30 miles, 30 minutes, access within 30 miles or 30 minutes. And I think that should be a goal. And if we do that, and we have locations, and we can use telehealth, we can use lots of other things, and then get the word out, and through our community health workers, if we start doing that, we can start breaking down some of that barrier that people are feeling so isolated, and no access.
Yeah, I think it's all of those things. I think it's interesting. I remember in our organization not long ago, as we all know that the primary care shortage is huge. And recruitment, if you were asked the question, what keeps you up at night? Probably most of us would say it's the lack of supply with a whole lot of demand. And how do we get creative, not only to deal with basic supply and demand, but the question that you asked. So not too long ago before COVID, the thought was, well, telehealth is going to be the answer to that. And COVID really pressed the pedal to really advance that in many ways. Post-COVID, what we're finding is the relationship, as you were sharing early, is everything. Face-to-face is always going to be important because of the relationship side of that. Now, that can still be done through telehealth, but it really starts with building trust and being really immersed in those communities and having those relationships. And I think all of us are kind of speaking to the same thing. And I think of one of our Native Hawaiian physicians, Dr. Marcus Iwani, over on the west side of Oahu. He's built such trust with those communities that he's helping us to really make sure we're listening and that we're hearing and that we are figuring out what that communication line is so that we're in close dialogue and not leaving these groups isolated to fend for themselves. That's so important.
So I'll just jump in here from more of the specialty perspective. I think that addressing this maybe sense of fatalism about, well, it's not there, it's okay, can get handled through word of mouth. We're a word of mouth community. And what we found, if someone who didn't have access, their auntie goes and they get a cardiology visit and they go, wow, I feel better. They talk to their larger extended family, and before long, they're there and they're accessing it. You can talk about and promote it, but until you have it there and people start using it, it's irrelevant. So if we really want to fix it, we need to have it available. And I really think people will actually use it no matter their cultural background because it's contagious in a good way.
I'm going to go to Dr. Dolan. How can community-based health and social care organizations better support hospitals with safe, patient, and family-centered discharges?
Is that on? Are we on? I'll give you it from the perspective of the physician who's receiving that patient from the hospital, from our office-based thing. What they can do is be that transition, that hand-holding, that passing of the baton in terms of, one, making the patient feel empowered at the time of discharge to know their medicines, understand it, being able to ask those questions. Because, to be honest with you, they're not going to ask the doctor. They're not going to ask the nurse. They're going to say, yes, doctor, yes, nurse. And so having that cultural ethnic group, have it just that person who's warm and friendly. I mean, Lonnie, who cannot be friends with Lonnie already, right? She has that warmth that brings her across. And then have that transition through to the office, wherever that may be, or to a community center someplace to make sure that there's that follow-up, that connectedness. Because all of these patients we talk about, I don't care if they're working for the county, the state, or they're a mom who's staying home with the kids, they feel a little bit shy in regards to calling up that, or I want to say feel less empowered. So to me, empowerment is a word as well to use, that yes, they can navigate their healthcare system, pick up the phone, be able to speak on the phone, or have someone who has that language be able to pick up and explain for them. That's where that kind of handoff with the social workers, community health workers. I'd love one in my office. If anyone wants to come and give me funding, I'd love it. Bring it on, because it's really important.
So, John, let me share something. As a surgeon, if I want to admit a patient and do an operation, it's one single phone call, patient gets a bed, boom, everything is arranged. As a primary care physician, if she says, you know, I don't really want Mr. Jones to go to the hospital, I wish I could have some help in avoiding a hospitalization, there's not a system in place to help. And so what we're trying to do, and on Oahu, and to some extent we're just making some progress on this island, is to have a complex care coordination team. Some of my team members are here, social workers, nurses, and if Dr. Dolan has a patient who is recently discharged from the hospital, or she's trying to avoid an ED visit or a hospitalization, they'll step in and help the patient, help Dr. Dolan. And I think that's an important part of healthcare, is avoiding unnecessary care. And I know there are payers in the audience, and we need their support, because what we're trying to do is avoid a hospitalization.
You know, we've got a number of questions. This one is specifically for Queens. Please share examples of the work that Queens is doing with social services to help people experiencing homelessness.
Okay. So we have a team. It's the Care Coalition team. And at the moment, I think there's a dozen of the workers. They're nurses, social workers. And what we do is we look for homeless patients who have more than X number of visits to the emergency room. And so if it's, I forget the number, but it's something like, let's say, more than 20 visits in 6 months, they are then assigned a caseworker, and the caseworkers go on the streets and visit the homeless patients, the houseless patients, and try to help them avoid another ED visit, make sure that they have the care that they need. And across the street from the Queens, there's Kauhale, that's Queens, HMSA, the governor. We have these little houses for people who are recently discharged from the hospital, who are houseless, and they're able to spend some time in those houses.
Thank you. Anyone can jump into this. What is being done to increase the pipeline of local students to attend medical school?
Well, I can tell you this has been a big focus of West Hawaii, is how do we grow our own, right? We see too many that come into the island, physicians. I'll give a good example. I used to recruit for physicians, and they come in and they find that maybe it's not a right fit, and they leave a year later. I mean, that's the reality. It's a hard place to live. So our focus is how do we create an education center of excellence? So we've focused on programs that will help build the resources to better support the physicians in their efforts. So we started a surgical tech program last year. We had 2 students that went through it, and I will say that both students didn't stay at Kona Hospital, and that's fine. This is a resource for the community. And this year, we have a cohort of 5 that have gone through. But this is a program that exists only on this island. It doesn't exist anywhere else in the state. So we're really excited about the efforts in trying to grow our own, because they're really, as it was said earlier, our greatest resource is our employees, our community. And we need to tap into that because it's there. We just have to inspire people to want to be in healthcare.
So the Hawaii Island Community Health Center, we're beginning to build our focus for growing our own. We've always had residents and students. We have PA students, we have MA nursing students, we have providers who are cycling through all the time. But those are usually people from the outside who want to come. And we find that that's really important too, because if you expose folks to the services and the programs, here, and you do, that's where the residency program that Hilo Medical Center has. If they get some training here, they're more likely to stay. That's research. But we do have to grow our own. And I think within some of the programs that we're doing, we're starting to work with the high schools. And every high school has a career pathways program. They're required to have a career pathways. We're trying to work with them and talking about health careers. And I know one of our staff is here, Marcy, from East Hawaii, from Hilo, is heading that up. And so that's one of the many issues. We have school-based clinics. We have 3 school-based clinics. We have setting up 2 more. By the end of the year, we hope to have 9 or 10 school-based clinics on the island. What does that mean? That means we're providing services right in the clinic, in the schools, and we're also able to educate and train and give people experience. Say, oh, here's a provider. This is something you can do. So it's, while we're providing a service, we're also trying to recruit.
You know, let me change lanes here because we have Congresswoman with us, but if you could see federal legislation that would specifically help the state of Hawaii, and in particular Hawaii Island, what would that federal legislation look like beyond what she announced is on the horizon today?
Where's the Congresswoman? No, I was going to ask her. Oh, well, wonderful. There you are. This is a little arcane, but it's been really important for us. So there was an omnibus budget bill that was passed that actually changed how rural health clinics are funded. So there are independent rural health clinics, and then there's ones associated with some of our hospitals like Kohala, Hamakua, and Ka'u. And they give, for a while there, you had the ability to set up a uncapped provider-based clinic, which allows you to do significant investments and have them reimbursed at your cost, so you can add things like specialists and rapidly grow them in a healthcare shortage area. And with some of the reasons we've been able to grow so much in East Hawaii is through uncapped rural health clinics. Fortunately, a couple of years ago, there was a change and they became capped, which has really limited our ability to continue to grow them. Not that we're ungrateful that we have what we have, but I can definitely work with the Congresswoman's health legislative advisor on the arcane pieces of this. But we've grown almost 75% in the last 5 years at Hilo Medical Center with our clinics, and it's been because of that federal program. And these types of things really make a big impact on our island.
So I've got one. There's a number of things, but one that I think hits all of us really hard is behavioral health. When I first came to Hawaii just about 3 years ago, I was shocked when a white paper said that the state of Hawaii is meeting less than 15% of the demand for behavioral health. And then when you go out and you look at the supply that's out there, they're capped out. So we've got to find ways to be able, right now there's an emergency proclamation that allows for behavioral health physicians to telehealth into Hawaii, on Maui anyway. And before that, there was an attempt to help with that, but the mainland doc would still have to connect with a Hawaii doc to prescribe the medications needed, waste of time, not helpful. But the emergency proclamation now is allowing that to happen. So unless we can grow our own fast enough, we have to find ways to deal with the licensing between states from mainland to Hawaii.
You know, let me again shift gears. I will tell you that the quality, I appreciate the quality of these questions, and we're not going to be able to get to all of them in this format, but a number of them actually belong in the breakout sessions as well. And one of them is going to have to do with state legislation, right? The idea that independent physicians are required to pay 4% GET on Medicare reimbursements while the hospitals are exempt from that needs to be looked at, right? And there's a whole range of things we can talk about. But here's where I want to go because we probably have about 15 minutes left. I want our panelists to envision that there's a parent company over all of you. And you're a subsidiary of this parent company. And this parent company is called the people of the island of Hawaii. Right? And so they're now the boss. They now, okay. As within that context, how would you report to that board on the nature of the collaboration that is going on horizontally between all of you, okay? Because there is a competitive set here that you're all obligated to advance. But at the end of the day, we have an obligation to every resident of Hawaii Island. And we cannot continue to let the zip code that we live in determine the quality of our education, the quality of our health care. Once that becomes the indicator, we know we're in trouble, right? And that's part of the storm that we're trying to address. So I just want you to use your imagination. You're now reporting to a board of the people, right? And that board has asked you to figure this out, right?
Primary care clinics all over the place. So nationally, it's known that if you have access to primary care, health care is better, health spending is lower. Unfortunately, primary care gets less than 5% of the overall spend, but we have the majority of the work in terms of managing the patients. I think there's almost a big piece of pie. Well, actually, it is a pie. And within that, there's different sectors of patients. There are patients who are FQHC, Medicare, Medicaid, that have significant social needs that you guys are the specialists on. There is a private sector of what I call the working stiffs of the county, who are the tax base. They work, they need to get in and out of the office really quick, get over and get on with life. There's the Medicare population who are aging, who need wraparound services, and there's different aspects of primary care that could help all of that. And there's different funding sources for that as well. And then with that, of course, looking at the top, we utilize all the specialists and that are in the different parts of the island in terms of inpatient, or I call it outpatient, or home hospital, which is a big term that's kind of out there as well now. So that would be my role of sort of helping oversee or report to the board and say, primary care.
We'll just come straight across with that.
Okay.
You're not reporting to the board.
Yeah. So, John, I think the way I would approach it is 205,000 residents on this island. What if we have a Kaiser-like system, right? You've got the insurance company, you've got the providers. And if all of us were to combine and work toward those 205,000 residents, then that's how Kaiser approaches their 275,000 residents in the state. We use the same approach, not with Kaiser, but as a larger group.
I'm in the subsidiary now.
But but the board, right? The report comes down to the quality measures for caring for a population. There's 5 domains. How is access, both for emergency care, elective care? How are we doing with that? Process. What are the things we do to make it easier for the patients? Outcomes. What's the survivals for heart attacks, for cancer? Number 4 is the patient experience. How are they experiencing this? And then the last is the infrastructure. Do we have navigators across the system? Do we have the same electronic medical record across? So that's how I would report to the board based on those 5 domains.
So in that case, we would need an investment to that infrastructure.
Yes, and I think that's why we're gathered here.
Right.
You know, it's about the policymakers, the purchasers of the health plans, the payers, the providers, and all working for the patient.
I know Representative Kila and Representative Kahaloa are here somewhere, so we'll be able to talk to them during the breakout as well.
Yeah, if anyone knows me, and my leadership style, and I've worked with many here, it's all about collaboration. Anyone and everyone that comes with a great idea, I'm always open to collaborate. And that's our position at West Hawaii. And you can see that is the most important thing that we can do is work together. Having lived on an island for many years, where you can walk across the island in 5 minutes, you realize really quickly that all you really have is the community around you to survive. That same idea exists here in Hawaii, and yet we're so disjointed in healthcare. It's because we all have competing resources, we all have competing agendas. But at the end of the day, like you so well said, when the patient's up here, our mission is the same. The first step that we did to really solve this, again, I go back to it because it's so important, is the EMR. The electronic medical record now allows us to gather the data. We can pinpoint and say, this population really needs help in this area. Let's get those resources to them. Let's take that to them, rather than expecting them to drive vast distances to come to us. And that's where we're seeing healthcare shift, not only here, but throughout the nation. So again, it comes down to the first step is laying the groundwork, the foundation. The medical record is key for that collaboration.
I echo what you just said about collaboration and what you both said. If I'm reporting to the board's the community, I'd start saying, what are the KPIs? What are the key performance indicators? Does everyone feel they have a PCP? You can go out and survey, and you'll find that 50% of the people don't feel they have a PCP. They can't identify. So what happens? They go to the emergency room. And so I'd be reporting up that, say, we're at 80%, now we're at 90%, now we're at 100%. That's one of the things. One of the other ones would be, we're seeing a decrease in disease, which can be measured by those of you in the hospitals, no offense, but you're seeing fewer patients because we're focusing on health and wellness. That's where we should be focusing. That's where the dollars. The other side would be that the dollars. How are the dollars being spent? Are they being spent on inpatient care? Or are they being spent to address food insecurity, housing, employment, and addressing the social determinants of health? And what are we doing in those areas with the dollars that are available? So I would look at medical indicators. I'd be looking at access issues and can people get care, like I said earlier, within 30 minutes. So you put those KPIs there, measure them, put them out, and communicate it back.
I'd probably ditto what Dr. Lim shared. It's a model. One of the things that I love about the Kaiser Permanente system is that the members' experience, at least the way it's designed, it's not perfect, and we are far from perfect, believe me, is that the patient makes one payment. They don't have to send a bill for a pharmacy, for labs, for radiology. That's all in one building. It's all in one location. I think from the earlier discussions, we need to be out in the community, and there's a number of things we're working on to do that. But I think the key is what Dr. Dolan was also touching on, and that is that we need to be all about prevention. We should look at it. Admission at the hospital is a failure of our system. Prevention is where it's at.
It's a little hard following all these guys. I'm supposed to come up with something creative here. But if I was reporting to the board, I would be both optimistic and pessimistic. And optimistic because in my experience, I think we are collaborating more. I think we're more aligned. But pessimistic because we're fundamentally in a system that treats healthcare as a commodity and not a public good, right? We're all responsive to our organizations. Right? And when we think about how can we put it all together and collaborate and yet still be our own organization with our own aims and our own constituents, you know, it's daunting at times. So it doesn't mean we should quit or we shouldn't figure out where to make it work and make the best of arguably a kind of just, well, I would say a screwy system. And being in it for 16 years, it is a screwed up system, but we can still make the best of it. So both pessimistic and optimistic.
Appreciate that. You know, and I know that tomorrow there's a working session that will delve into this even deeper. Here's what we do know. Status quo is not acceptable. Status quo is not sustainable. We should be grateful for status quo, but we cannot settle for that, okay? Because there are people falling through the cracks as we speak, as you know. But I think being respectful of the individual organizations and the fact that you are accountable to an immediate board. In my opinions, it would be great to see 2 to 3 members of each of your boards convene in scenario planning as to what that might look like so that some of the heat is off of your back as CEOs, right? And just begin to explore it. A year ago, Hawaii Community Foundation and the Hawaii Executive Collaborative convened a scenario planning and we're a year into it, but they brought a circle of 40 people together. Bank presidents, Walter Riddy from Molokai, Antipua Kanahele, and the president of Matson, right? And so the whole idea was to get a group of 40 that were as diverse as you could make it. And all of us entered that process saying, what am I doing here? I don't have anything in common with General Hara, right? I don't have anything, and you could feel the tension in the room. And the facilitator was a company called Rios Partners, and Mayor Roth is part of this process too. And Rios, the principles of Rios were involved in helping South Africa move from apartheid to democracy. Not perfect, but transformative. And they work in Colombia, and they work in different places throughout Africa. And one of the things that disciplines we had to learn when we spoke was to talk about what could happen, not what should happen. Once I start talking about what should happen, immediately there's going to be protective walls, defensive walls going up, right? Because I have no right to be in that space to make such an assertion. But when I take the mere discipline of, and you used to get penalized, they'd go around with post-it notes. Jack Wong from Kamehameha Schools said, well, we should, you got, a yellow flag. So the discipline is what could happen, and just to keep stirring the imagination and the creativity and the innovative spirit, right? A number of us touched on this whole voyaging epic, and I talked about my experience with Google X and moonshot thinking, right? Because what we're talking about fundamentally is the things that we're currently doing, we gotta keep doing. But what are the moonshot ideas? And those ideas involve people outside this room, right? They involve a harmonious Congress. They involve a harmonious state legislature, right? That can think through this and help us reinvent some of these areas that would enable enhanced and increased funding, resources for enhanced collaboration across the board, right? And I can remember on that voyage when they left Hilo, 2 days out, it's a crew of 15, and the canoe got all the way to Tahiti, and then navigator Nainoa Thompson flew back to Honolulu, and I happened to be in a meeting with him right when he got back. And I said, wow, you got there in record time. And he said, 2 days out, 6 of the 15 board members, crew members, got deathly ill. Couldn't function, couldn't hold down food, right? And he had a decision to make at the end of day 2 as to whether to turn the canoe and go back to Hilo. And decided not to because of the risk of what would happen if you're at the point of breaking down or breaking through. So I said, the 6 must have felt really bad that they weren't there to help their fellow crew members. And they had figured out that the cumulative weight of that 6 was roughly 700 plus pounds. And so their body weight collectively would be moved to different parts of the canoe depending on the conditions of the sea. So that even the sick were contributing, even the weakest on the canoe were contributing to the success of that voyage. Okay? Because when you turn back, what Nainoa knew, when you turn back from this moment in time, which is why you and I cannot turn back, okay, when you turn back, the erosion to people's confidence in themselves, in one another, in the purpose of the mission, all of that begins to erode, right? And we're living in a time where we either break down or break through. And as Congresswoman Tokuda alluded to, the resilience of our people gives each and every one of us the confidence that breaking down is not an option. Failure is not an option. But we're going to need the coordination of and collaboration of everybody in this room to make a unified statement to the Hawaii State Legislature, a unified statement to our congressional team, to be able to bring the support so that where status quo is today, 5, 10, 15 years from now, we can measure the bar being elevated, and it's being measured in each one of these valuable entities that are here on this stage and seated throughout this room. So at this time, I just want to thank our board members. By the way, the first board meeting is a week from today. No, join me in thanking our panelists. It's truly wonderful. Thank you.